offering your time for the
Yeah,
show.
my pleasure.
Yes. So let me just do a quick introduction. Welcome, everyone. This is Real Health Talk with Dr. Coring. I'm here with a special guest. This is a show where we actually educate our minority patient population on diseases that are specific to minorities. My name is Dr. Coring. I'm a board certified internist, and I'm here with Dr. Kevin. Is it Lai?
Lee.
Lee, Dr. Kevin
Yeah.
Lee. Introduce yourself, Dr. Lee. Tell the people who you are.
Well, my name's Dr. Kevin Lee. I'm a vascular and interventional radiologist. Um, and with basically, I think that those terms are kind of a bit of a misnomer because when people hear radiologist, they think of a physician who uses high level, imaging equipment for diagnosis and
Mhm.
interpretation diagnosis. And being an interventional guy, I mean, we're doers, right? So like,
Mhm.
you got the radiologist, he's a diagnostic guy, very intelligent, he or
Mhm.
she, they're great thinkers. We as interventionists, we're like more doers, right? So
Yes.
maybe we're
Yes.
not so smart, but but we're in there fixing and doing stuff. Um, and so I'm an interventional guy. We have outpatient facilities in Georgia. In
Okay.
Atlanta, we got three facilities. We're Georgia Endovascular Associates. We're endovascular specialists.
That's fantastic. And the reason why I'm glad you're here and on the show is because, as I mentioned, I really cater this content to minority patient populations. And there seems to be somewhat of a silent, I would say, epidemic or even pandemic of essentially amputations, to be quite frank, of the lower
Gotcha.
extremities. And it seems like it's driven by peripheral artery disease. And I was
Sure.
hoping we could spend a lot of time discussing that. But can you tell the people from your own experience what is peripheral artery disease and how do you manage it?
Sure, sure. So peripheral artery disease, I mean, it's a manifestation of
Mm.
a systemic process that's going on. So when we talk about atherosclerosis, I think everybody has a general understanding of atherosclerosis. Atherosclerosis is hardening and narrowing of blood vessels. Certain risk factors of age, smoking, diabetes, high blood pressure, hyperlipidemia, those types of things with those risk factors, and then other risk factors such as obesity and inactivity, maybe chronic kidney disease, things like that. So this kind of systemic or body wide atherosclerosis is a
Mm.
narrowing and hardening of blood vessels. And so PAD, peripheral artery disease, that's like the limb manifestation.
Mhm.
Um, and when patients get peripheral artery disease, the atherosclerotic changes in their going to their legs, typically their legs, but their arms too, but typically their legs, they'll have something called claudication. And
Mhm.
claudication is kind of like cramping, pain, numbness with exertion, and
Mhm.
that relieves with rest, and that's like
Mhm.
reliably reproduced. So like a patient, with claudication, they'll walk,
Mhm.
I don't know, 100 meters or so, and
Mhm.
then their legs will cramp up, get numb, and then they'll rest, and then that'll improve, and then they'll get up again, walk or another 100 meters. So it's just like reliably produced. So
Mhm.
that's what claudication is. That's one of the telltale manifestations of peripheral artery disease.
Absolutely. So when patients come see you,
Sure.
what level of severity typically are their peripheral artery disease?
Well, I think that once somebody's symptomatic,
Mhm.
that they are, I would grade them as, kind of moderate to severe.
Mhm.
Because if they're symptomatic, then they've got hemodynamically significant stenoses or narrowing or blockages.
Mhm.
And I think like um, if you kind of classify, if you want to classify, how severe it is, it's
Mhm.
kind of dependent on, the location of the narrowing of blockage, the length of segment, how much is involved, other territories, whether you're talking about the pelvis, the thigh, the calf. Um,
Mhm.
So, I think there's complexity and intricacy,
Mhm.
but I think once somebody becomes symptomatic, I mean, I would say that they're kind of like on the severe narrowing, or like once people get blockages, it's
Mhm.
they've got some vascular issues for sure.
Yeah, and I think the point I was trying to elucidate is
Mhm.
typically when you're symptomatic and the symptoms you explain really, really well, it's almost at the point where it may be, not too late because that sounds a little bit
Sure,
drastic, but it seems as though it's better, obviously, to catch these things before it get to the point where you're symptomatic. And
of
that kind
course.
of brings me to my next question. Like,
Yeah.
what are the defining risk factors that we could really target to actually prevent patients preventing with symptoms?
Okay, so some of these risks, some of those factors, you hear a lot about, right?
Hmm.
So, somebody smokes, that's a like, I talk about atherosclerosis being systemic, right?
Yeah,
So,
yeah.
smoking causes like a systemic inflammatory response, right? So,
Hmm.
people think, oh yeah, it affects my lungs, right? Well,
Yeah.
it also affects the heart because it affects the heart blood vessels, right?
Hmm.
Also just causes inflammation throughout the entire body. And then, and the blood vessels are the circulation. So anything that enters the body really
Hmm.
enters the circulation. So whatever, noxious chemical or whatever, that's going to affect all the blood vessels throughout the body negatively.
Hmm.
Um, and then, there's other things that, there's things that we can't control, right? There's age, we all grow older.
Hmm.
That's something we can't control. But there's things like, I think, diabetes is another
Hmm.
main risk
Hmm.
factor.
Hmm.
High blood pressure is another risk factor.
Hmm.
Having a lot of cholesterol in your blood, that's another risk
Mhm,
factor.
mhm,
And I think I, also elucidated about the having, obesity. I mean, and that
mhm,
might be just a component of age too. When we grow older, our hormones change,
mhm,
our body habits changes. We have less muscle.
mhm,
Might lead to inactivity too. So, and then inactivity and obesity, they kind of like feed each other. Um, and then there's also genetics,
mhm,
and we do see, a predominance in certain cultures or ethnicities.
mhm, mhm. No, that's fantastic. And as an internist, what I typically tell people is the big five, obesity. We talked about smoking. We talked about hypertension, diabetes, and inactivity, immobility. And so,
Yeah.
if you have these risk factors that you're mentioning, what about screening? How will you advise our patients for screening? Yeah.
Yeah, I mean, that's kind of a tough question.
Hmm.
I
Hmm.
think that, you guys being internists, I mean, you guys are the front line of everything.
Hmm.
You guys are very intelligent doctors. You see it all, right? And
Hmm.
you got to
Hmm.
like try to like weed. You got to try to get through the weeds on everything.
Hmm. Hmm.
Um, I think, as far as screening goes, I mean, yeah, I
Yeah.
mean, early screening is,
Yeah.
is a thing. I mean, we could start. I think probably the easiest and the earliest screening thing would be a good physical exam.
Yep.
Um, then after that would be kind of like looking at the risk factors, modifying them.
Mhm.
Um, but I think a very easy early exam would be, it's like a screening modality would be like the ankle brachial index, where
Yep.
it's basically blood pressure, and
Yep.
then looking if there's any differences there.
Mhm. Exactly. And one of the points I want to stress here is, if you have the common risk factors, the screening is non-invasive. It's
Yeah,
literally taking blood pressure of the lower extremities and comparing it to the upper extremities,
sure. Yeah,
and it put you in a category based on what we find. And so, if you have these risk factors like obesity, hypertension, immobility, smoking, strong smoking history, if you're African American, you have a family member who has peripheral artery disease, you may have a genetic predisposition. I think you should see a primary care provider just to do simple non-invasive screening for this disease, because as Dr. Lee mentioned, once you become symptomatic, then there's maybe some invasive procedures on par for you. And I think it brings us to our next discussion. Can you talk about why you think there's a disparity in managing peripheral artery disease when comparing Black patients to Caucasians?
So I think that it's probably it's multifactorial.
Mhm. Mhm.
So when I was hospital based for a very, very long time.
Okay.
And, kind of like and then, now we've taken our centers and we've made it accessible to the community and all that.
Mhm.
Right. But, there's kind of like a different thought process that happens, like, like in the acute setting or, in a hospital setting, like wherever the patient presents. Right. So like, let's say, let's say like the patient presents at, an emergency room and, like I said, the atherosclerosis is a systemic process, right?
Yes.
So if they're having a stroke, that's managed right away. If you're having a
Mhm.
heart attack, of course, that's all man. These are all emergencies, are just being managed right away, right? And the
Mhm.
patient might, but we also know at the time, they probably have, problems with their legs, right? But
Mhm.
of course, what we're going to do is we're going to take care of the brain, we're going to take care of the heart, and then we'll go follow up with your primary care doc, and and he'll lose some weight, or do some more exercise or whatever, you know what I mean? And it just kind of gets like the it's like triage, right? So I think on
Mhm.
the level of this systemic process, it's like this claudication, or like is like kind of pushed down on that triage level,
Mhm.
is less severe, and it's kind of just like shuffled off.
Mhm.
So I think that can be an issue.
Mhm.
um and then as far as disparities, I mean, I think that it's insights, awareness, and access to professionals or specialists. I mean, I truly believe that the best way to manage any condition, but specifically peripheral artery disease, is multidisciplinary. I
Yeah.
mean, a great primary care doc who gets on board early, who's managing all those risk factors, getting the diabetes under control, getting the high blood pressure under control, getting those high cholesterol under control. I mean,
Mhm.
you got to have that. You have to have him or her throughout this entire process,
Mhm.
whether we're talking about
Mhm.
interventions or surgery.
Mhm.
And so, but what I really believe is access to
Mhm.
a multidisciplinary team, or professionals, or a
Mhm.
cohesive team that can manage it. So
Mhm. Yeah, you said something that was really profound that stuck out to me. It seems like a patient who have some type of manifestations of atherosclerosis, where it be a stroke or MI, it seems like those patients are great candidates to at least be screened for peripheral artery disease.
sure.
But do you
Yeah.
see that happening a lot, or
I
from your
I
experience?
think I think it just gets shuffled off. I
Yeah.
think it just gets pushed down on that priority. And
Hmm. Hmm.
like everyone's addressing,
Hmm.
what happens, the recovery,
Hmm.
because it's not just it's not just the stroke or the heart attack,
Hmm.
it's also the morbidities, or the sequelae of those things. And
Hmm.
and patients might be healing from a surgery or an intervention too.
Hmm.
So, it just I just feel it can get
Yeah.
shuffled aside.
Yeah. I was hoping we could take a moment just to really define what is atherosclerosis for our audience. I think you and I
Okay.
have a great idea what that is, but
Yeah.
I think I want the audience to really understand, once you have atherosclerosis, and you're really doing a good job telling us it's systemic, meaning, if you have it in one location, it's probably in another location as well. I grew up unfortunately poor, and I grew up with roaches, and I hate to use this as a comparison, but we already know, if we see one roach in the house, there's another one somewhere else. And
Yeah.
and I
Yeah.
think that's kind of what it is with atherosclerosis. Maybe you can tell us.
Yeah, I mean, I think, I mean, that's kind of like a great example.
Mhm.
I mean, in certain respects, I mean, like I think that, if we look at blood vessels, I mean,
Mhm.
we can look, think about them as plumbing, right?
Yes.
Like, the good thing about a human body is it has its ability to kind of repair itself.
Mhm.
But the issue is that, it can, those repair mechanisms can be overcome, and
Mhm.
like, overcome in a bad way, right? And so, but if you think about, if you use your example, and then if you take like a plumbing example, like, when somebody has their shower drain,
Yeah.
and they're just like, hey, it's clogged, right? you know it just didn't happen just right then and there.
Mm-hmm.
The hair or whatever, shampoo, all the soap scum residue that's been building up for,
Mm-hmm.
a length of time. And then it gets, and then it's just like the straw that broke the camel's back, that one piece of hair or something like that, or
Mm-hmm. Mm-hmm.
whatever that, blocks up the whole thing. Yeah. So it's just like, for you, like yeah, your example is great. It's like one of those things. Well, if you smell smoke, there's fire, right?
Yeah.
Um,
Yeah.
but with this is like, well, so I think this comes back to what it is, right? I think that there's a misconception
Mm-hmm.
about peripheral artery disease or heart attacks or strokes or
Mm-hmm.
amputations or whatever it
Mm-hmm.
is that, it only happens to the elderly,
Yeah.
it's sudden, you know, all these types of things. And I think, that gives the perception that this is like something that people they can't control,
Mm-hmm.
right? If it's
Mm-hmm.
something sudden,
Mm-hmm.
whatever, then you're like,
Mm-hmm.
okay, well, it's just bad luck, right? Or whatever. But
Mm-hmm.
these are things that we can manage over time.
Mm-hmm. Mm-hmm.
Yeah. So I don't know if I answered your question. I
No, you
mean,
did. Fantastic. And I
yeah.
think another misconception, especially when I hear patients discuss, vascular health, I think patients get confused with arterial health and venous health, peripheral artery disease and venous insufficiency. Can you help us understand the difference between the two?
Well, I mean, so the arteries are, the red blood. It's like
Mm-hmm.
the
Mm-hmm.
oxygenated blood that's got the heart pumping, behind it. You feel the pulse. That carries oxygen and nutrients to organs and the extremities, right?
Mm-hmm.
And veins kind of do the opposite. Veins, they're bringing blood back, right?
Mm-hmm.
So veins, they've got carbon dioxide and waste products that need to be, kind of brought back to the heart and lungs for recycling.
Mm-hmm.
And so, so as far as arteries go, that blood gets pumped by the heart.
Mm-hmm.
And as far as like varicose veins and venous insufficiency, there are valves within the veins that they're like one-way doors that keeps the blood going the right direction, right?
Mm-hmm.
So there's kind of gravity, there's like muscular contraction, all these things that kind of like move the blood up these valves, like kind of like an escalator or like an elevator, right? And so when those valves get damaged, those one-way doors get damaged, the blood just falls back down. And so
Mm-hmm.
therefore, so arteries, the issue is that, if they're not working great, then you don't get enough oxygen nutrients. You don't have, and that's a problem. And then when veins aren't working well, then the carbon dioxide and waste products are just accumulating down wherever the problem is. And, that's
Mm-hmm.
also bad too. and
Yeah.
and they and the skin manifestations can be similar. I mean, they can lead to discolorations or ulcers or whatever. So you guys being internists, I mean, you
Mm-hmm.
guys have to like try to decipher all these things. That can be very complex.
Mm.
And this gets back to like kind of having that great multidisciplinary team. You need that
Yeah.
the fantastic internist who's like the spearhead of all this,
Mm-hmm.
and then being supported by
Mm-hmm.
vascular specialists.
Mm-hmm.
And and I think that's kind of like what we're trying to do with our paradigm
Mm-hmm.
is and our philosophy is to get our ability to help with diagnoses, help with
Mm-hmm.
evaluation
Mm-hmm.
comprehensively, and then also have comprehensive treatments and be available for you all,
Mm-hmm.
and
Yeah.
and help your patients.
That's great. And, I think this conversation is leading me to ask a pertinent question. And I think that's when you get your new referrals or your new consults, I wonder how many, if we do a percentage, how many of those patients are asymptomatic?
Um, I think that, it's kind of like when you look at a screening exam,
Hmm.
right?
Hmm.
Like screening is you have like a net and you're trying to catch everybody. So,
Right.
I think there's like a sensitivity, right?
Hmm.
Like sensitivity is good for a screening exam.
Hmm.
And then you
Hmm.
got specificity, which,
Hmm.
says, well, this is what
Diagnostic.
it is when it comes.
Exactly. Yeah.
So for us, I mean, uh, by the time we see patients, they're usually kind of like, they've kind of fallen through that, sensitivity screening net,
Hmm.
and it's more specific for us. So I think that, I would say that, we see slightly more,
Hmm.
asymptomatic than symptomatic, but that's exactly what we want it to be. So you're making sure you catch everybody,
Perfect.
right?
Perfect. And I think that's what I wanted to hear. And that's actually surprising to hear, to be honest. But it's also encouraging that, our colleagues are referring our patients who actually screen positive for PAD, who are asymptomatic, are still being funneled to you for interventions. And it brings me to my next question is, how are
Sure.
we intervening on these patients once, or at least just go through the dogma of interventions? We talked about claudications
Right.
when you're symptomatic at that point. Are we doing exercise programs, or are we going to invasive interventions? Can you talk about it?
Yeah, I mean, I think so. Yeah, I kind of want to just take a couple steps back. I
Sure,
mean,
sure.
when we, when we see a patient, right?
Hmm.
You know, there's, we, you all send them to us, and we already have kind of like the risk factors, and we're already
Hmm.
seeing these guys. Number one is, we clinically we've got to decipher, like, well, is it, what kind of vascular issue is it? Is it
Okay, okay.
veins? Is it arteries, or is it both? Right?
Yeah.
So so we do a more focused exam, and then comprehensively we've got an ultrasound machine and a vascular ultrasound technologist, and so that's fantastic in the fact that we can physically look for both conditions, whether
Hmm.
they've got vein problems or arteries or both or whatever, and and so and then but it kind of comes back to like where patients kind of fall through the cracks, right? So like, I mean, I'm not sure if I'm not sure if I'm going to bring up more questions and answers, but if you have a patient who's an older patient, and
Hmm.
they're not very active,
Right,
right?
right,
And they're not very active, and they got PAD, and
right.
but they're asymptomatic because they're not active,
Perfect.
right?
Yeah, you're
But
right. Yeah,
if they were active, you'd have to, you'd know that they've got, severe disease, right? And
fair.
so like, so for these patients, it kind of becomes like kind of a gray area. Like, do you
Mm,
treat them because you
mm,
can't do better than asymptomatic, right? But
mhm,
and so
mhm.
you kind of wait for them to kind of develop ulcers, or
Okay,
whatever that kind of
okay,
like says, hey, we got to do something
okay,
now.
okay.
But then by that point, then you're talking like, well, their diagnosis is getting pushed back. You know what I mean? And that means
Mm,
that, you've got more involvement of segments, multiple segments,
mhm,
multiple lengths. And then as you get
mhm,
further down towards the feet, like towards the tibial area, or even like the
mhm,
foot vessels, like,
mhm,
things get really challenging to work in.
mhm,
And so I think, I
mhm.
mean, I don't, I think I'm like kind of raising questions. I'm kind of, raising
Yeah,
more questions. I'm kind of like
yeah,
getting into what you're talking about, but,
yeah.
so, yeah, so,
But yeah, that's interesting. Especially nowadays, our patient population is getting older. People are living longer. And so when you have that PAD patient who's inactive, maybe it's a nursing home patient. It's
yeah,
very interesting to understand your approach of how you're caring for that patient population. But let's say
sure.
you have a patient who's is active and they're in their
Yeah.
70s, and they have the diabetes history, uncontrolled hypertension, and the claudication. And,
Mhm.
they refer to you, what would be your methodology of treating that active patient?
Well, I mean, I think the first line, once we identify that a patient needs, you
Hmm.
know, um, uh, an endovascular procedure, like they're not being, they're like refractory
Okay.
to, all the medications, all the lifestyle changes, all
Right.
the, doctor referred, exercise programs.
Right.
So they're definitely an interventional candidate, and so the beautiful so end up so we're everything we do is through the blood vessels. So that's like endovascular. It's like we're working through the blood vessels,
Hmm.
and and that's very technical. But the main thing, the main point that I want to get across is when we work through the blood vessels, what we're doing
Hmm.
is we're reestablishing flow
Hmm.
in native blood vessels.
Hmm.
So like a native blood vessel has like a long term has a long term patency better than like somebody who gets a surgery and needs a bypass or whatever. So the
Hmm.
main thing is to give this patients like the best longevity of procedures is to open up these native blood vessels, and then try to do it without leaving anything behind like a stent or anything like that.
Okay.
Just to so we've got a bunch of devices, and one is to do atherectomy, which is kind of, well, actually, let me take a step back, right?
Okay.
So we have our advanced imaging equipment, all this interventional guys, and
Mhm.
then that's like, we kind of like look at, the blood vessels, from, using like an X-ray camera.
Mhm.
And, and then we also have devices where we put a little ultrasound probe through the blood vessel itself. It's called intravascular ultrasound. It's
Okay.
it's an amazing tool, but it looks like a little wire, right?
Mhm.
Um, but everything that we do is goes over these like guide wires, goes through the vessels themselves, and the goal is to do atherectomy, where we kind of grind out the plaque, and then angioplasty, where we kind of stretch open those areas of narrowing. If everything looks good, we're done.
Yeah.
But sometimes, they collapse down, they need a stent or something like
Yes.
that. But we try not to leave a stent unless we really have to.
Got you. And so I think what I want to share with the audience, it seems like the approach is a highly methodical approach. At first, we try to do things that's non-invasive, so exercise programs, and then we go with maybe some blood thinning agents like aspirin, for example. Then if we can't get any traction there, you get referred to an endovascular specialist if you're refractory to exercise approach or medications. Then the intervention would be maybe something that's somewhat invasive, but we're still not there where we're talking about amputations, right?
Sure.
Yeah.
Yeah.
When would we start talking about amputations? When does those conversations arise?
Yeah, I mean, I think that gets to the point where you got such severe disease that,
Hmm. Hmm.
things don't stay open, or we can't open them. So I mean, so kind of like, taking a couple steps back, like,
Hmm.
like the beauty of an endovascular procedure means that, um, patients basically recover within minutes to hours. They get the procedure done, and then,
Hmm.
they're back home or back in the real world.
Hmm.
And then when patients start needing surgeries, such as bypasses or whatever, then,
Yes.
obviously they got to heal from a surgery of, whether,
Hmm.
days or weeks, right?
Hmm. Hmm.
So, so everything that we do is just to, maintain these native blood vessels. And if a patient needs to start getting surgeries, and then, or things start closing down,
Hmm.
yeah, the goal is to preserve the limb so that we
Yeah.
don't have to do any amputations.
Right. And I think in our community, when I say our community, the African American community, it seems like it's a misnomer, or it seems like there is a misconception that when you start having these problems and these symptoms, the goal is to cut right away. And I think what I want to drive home is there's a stepwise approach to this. There's a methodical approach, and we try to be smart about it. And there should be, exercise therapy being offered. There should be medicine being offered. There should be maybe some non-invasive procedures being done, and maybe invasive procedures afterwards. And then there comes the amputation. But it's definitely down the line.
Yeah,
Um,
for sure.
yeah.
And I think that, like, for, you know it's not going through, it's not someone's getting medication and doing the exercise programs,
Mm-hmm.
and then that stops, and then it goes to endovascular procedures, and then
Mm-hmm.
that stops, and it goes to surgery, right?
Mm-hmm.
Like, like, for me, like, I need, the internal medicine guys, the primary care docs, or whoever,
Mm-hmm.
throughout this entire process, right?
Mm-hmm.
Because
Mm-hmm.
the medical management,
Mm-hmm.
maintaining, so exercise programs, I mean, they're great, right? But,
Mm-hmm.
they're rigorous,
Yeah.
right?
Okay.
Um, and
Okay.
so, but the goal about, the exercise program is that, there's angiogenesis, and then two, there's collateralization, right?
Okay.
So these exercise programs, with the angiogenesis, is the growth of new blood vessels. Okay. And
Mhm.
so that's what these exercise programs do, right? So strength and kind of, it's not just strength and conditioning or whatever, but
Mhm.
it's more about, like, the recruiting or growing new blood vessels. So throughout, like, like, let's say you've got a patient, and they're being, managed, as effective as possible by their primary care doctor or internal
Mhm.
medicine guy. They
Mhm.
come to us,
Mhm.
we're just opening up the blood vessels. but they still have this systemic issue, right?
Yes,
If they need to
yes.
quit smoking, if they still
Mhm,
need their diabetes managed, they still need all that.
mhm,
We
mhm.
open the blood vessels, and the patency is dependent on still continuing to manage these risk factors, because the risk factors will still will cause the same issue to happen if they're still there.
Exactly. Exactly. And I want to use that as an opportunity to really stress the importance, especially me being an internist, of prevention. That's essentially the whole goal, is prevent you from having symptoms. And the best way to prevent is modify, at least the lifestyle risk factors, such as smoking. And arguably, diabetes is a lifestyle risk factor. Um, Allegedly, you can change your diet, change your lifestyle, and cure yourself of diabetes. Hypertension may or may not be, but oftentimes, sometimes, if you change your life and your lifestyle, make better lifestyle choices, you can reverse hypertension as well. Obesity is reversible through lifestyle modification and choices as well. So essentially, peripheral artery disease can be prevented just by making lifestyle changes. And therefore, Dr. Lee could stay home and do other things.
Yeah, yeah, put me out of business. I wouldn't
No,
mind
that's not.
fishing. I wouldn't mind going fishing.
That's not the goal, Dr. Lee. But I was trying to stress a point.
Yeah. No, no. I mean, I think, yeah, I mean, the there there is, I think that, there is a sense of patient empowerment here.
Hmm. Hmm.
They can kind of control their own destiny and kind of
Hmm.
control where this is going.
Hmm.
And reverse the process too. I mean, things,
Hmm.
you can, turn back the clock a little bit,
Okay.
with, you just got to be really committed. But,
Yeah.
I
Yeah.
think it's kind of worth it.
Yeah. I think up until this time, we've been talking about the patient who's essentially asymptomatic has been referred to you and start the dogma of treatment and managing peripheral artery disease. But let's take a quick turn. Let's talk about the ugly side of it. Let's talk about the patient who's basically presented to the ED with cold limbs and full-blown limb ischemia. Let's talk about, one, how you manage those patients, and is there a disparity with that patient population?
I would say probably not once
Okay.
they get into the hospital.
Okay.
That the cold limb is a medical emergency, and
Yes.
you start having tissue loss within hours.
Okay.
So at that point, if a patient presents with, with those types of findings, and they're
Hmm.
not really symptoms at that point, those are like
Yeah.
true signs, right?
Yeah.
These are like objective, they're, then the interventions become emergent.
Hmm.
We're working on these patients like within hours.
Hmm.
And basically, again, is to restore blood flow through the native blood vessels. But if they've already had surgery, we're trying to reestablish both, through their whatever native blood vessels they have left, or whatever surgical bypasses they have. But
Hmm.
at that point, it gets quite involved.
Hmm.
Patients are probably, admitted to the intensive care unit,
Hmm.
because we've got to run a medication that breaks up blood clot.
Hmm.
And that medication, if it's too high in dose, can, the patient, is at a risk for kind of internal bleeding,
Yeah.
right? And so, it gets to this, it's more of like a life and death situation.
Absolutely.
Um, yeah.
Absolutely. And what I wanted to really ask is, do you see more, Black folks coming in with those, with that presentation, with that medical emergency, or is it pretty even split?
I mean, I think it's pretty. I don't know.
Okay.
It'd be
Okay.
anecdotal. It's almost
Okay.
impossible for me to say. I mean,
True.
is it typically? I mean, I guess there's a higher predominance of, of older patients.
Yeah.
Um,
Yeah.
I think that, socioeconomic status, I think, plays a role in that.
Hmm.
So, because they've don't have the access to preventions, or they don't have the access to early on,
Hmm.
management, that,
Hmm.
by the time, they're in a really bad spot when they show up.
Hmm.
Um,
Hmm.
so I mean, I think, yeah, I mean, it's really hard for me to say.
Fair. And
Yeah.
what would you tell a patient, who's a candidate for amputation? And that's pretty much the last line. But they
Yeah.
don't want to do it because of aesthetic reasons, because of lifestyle reasons, how would you coach that patient, or how would you
Yeah.
talk to that patient with that?
So for me, I mean, I'm not a surgeon that does
Okay.
amputations, so I
Okay.
don't do a whole lot of consultation for that.
Okay. Fair enough.
Um, but I think that there is life after that limb loss.
Okay.
But there's certainly things that we have to manage. From there's kind of like wound healing,
Hmm.
infection,
Hmm.
you know, and
Hmm.
then I mean, we certainly want to keep these patients moving, right?
Got you.
It's
Got you.
always about keeping them moving so they can
Yeah,
maintain what they have,
I
and
hear
then
you.
prevent blood clots from forming in the veins or whatever. So it's all about keeping them empowered and moving around.
Absolutely. And just to end really quick, just give us a plug of what you guys doing at, Georgia Endovascular. What's new? What do you guys got? What, if anything, do you guys got anything, any programs going on for PAD? Anything patients could plug into? Just, give us a glimpse of what you guys got going on at
Yeah,
Georgia.
so I mean, so we're endovascular specialists,
Hmm.
and the platform, what we've done, um, what this company has done is kind of bring these, a facility that has, so what we're doing is what we've done is we've brought facility and physicians and providers who are comprehensive in evaluation,
Hmm.
comprehensive in diagnosis, and comprehensive in treatment and
Okay.
management of peripheral artery disease.
Okay.
And 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 I think what it really, our paradigm is, our philosophy is to bring this out in the community and make it
Okay.
accessible,
Okay.
because I think that the accessibility to a multidisciplinary team or
Hmm.
specialist, that might delay somebody, and they
Hmm.
wind up presenting
Hmm.
later with
Hmm.
more severe disease.
Oh, that's
And
fantastic.
and then the other thing that we do is, we work, our goal is to work in tandem with the surrounding communities and their, and the physicians and providers in the surrounding communities, dealing with, who see, you guys like the spearhead, like you're the front
Hmm.
line. And
Hmm.
so we come to you guys and say, hey, this is, we're here, and we're here to be part of your team, and we're here to be the specialists, and
Hmm.
and you guys are, you're
Hmm.
managing the patient, and we're here to help. And
Absolutely.
whether, and like and going back to, veins and arteries, it could be nebulous what it is. They could have either or both,
Right.
and it's almost impossible to decipher without an ultrasound machine sometimes, right? So
Absolutely. Hmm.
so we offer that, and just to help you guys. I mean, you could, you're only so smart. You can't see through somebody's
No,
leg, right? You can't see through their skin,
that's the
right?
truth.
So that's what we're here for. We're,
Yeah.
we're here to work as a team, and then between
Mm.
all of us, the patient has access to a comprehensive
Mm.
team of specialists or whatever. Yeah.
That's fantastic. And I think you mentioned it a few times. One of the biggest barriers is access. And let's say we have an astute caregiver or astute patient who actually has these risk factors that we talked about and want to get screened, or at least want to see you for an evaluation. How does that process look for them if they don't want to go through their provider or their PCP, or maybe they don't have a PCP?
I mean, we always 100% work with a primary care doc or
Okay.
internist. So
Okay.
if we see a patient who's just comes in off the street,
Yeah.
we always want them to be comprehensively managed, right?
Got you.
And
Got you.
so we refer them, and for whatever, if they don't have a primary care doc, they're definitely getting one. They're
Okay.
definitely getting a referral
Okay.
from us.
That's great. And that's exactly what I wanted you to say, because I think, especially with the Black community, I think we don't do a good job having primary care doctors, unfortunately. And that could create, and I'm sure that adds to the disparity and that creates disparities. And so if you're listening to this and you have these risk factors that we're mentioning, the first step is to get a primary care physician to get referred. for screening. But if you don't, then you can still gain access to Georgia Endovascular, and they will refer you to a PCP. But I think that's a huge, huge piece of the puzzle of comprehensive care. You definitely need a primary care physician, and that's kind of what I preach on this channel as well. I think everybody needs a primary care doctor.
I mean, for sure. I think that, I think um, the primary care physician is really is kind of the spearhead in all
Yeah,
this.
yeah,
And because it's there's other things going on, right?
right.
There's other conditions or other things that need to be taken care of. But I
Yeah.
think one thing that I think is not measurable is that you guys are like the epitome of like a patient advocate,
Mm-hmm. Mm-hmm.
right? Like
Mm-hmm.
they walk in the door and they're, they might have been kind of like, shuffled off,
Mm-hmm.
like let's say they go to the emergency room. They're like, okay, well, you don't have appendicitis, you're not having a stroke, whatever, right?
Right.
And
Right.
so, they get kind of shuffled off and so they don't really have, a healthcare advocate. And I think that,
Mm-hmm.
that's something that you guys do that we can't put a price on, because
Mm-hmm.
you advocate for the patient. You're like, hey, this patient needs something, they need you to see them, or this person
Mm-hmm.
to see them. You're yeah. I mean, you're kind of like the node, right, of like of
Absolutely.
the system, right? So yeah. So I mean, yeah. There's nothing more that I appreciate than a fantastic internal medicine doc or a primary care doctor.
Well, we appreciate you. We appreciate your services, taking care of our patients in Georgia. I wish you much success in 2026. Happy New Year to you. And any closing remarks you want to share with anybody regarding peripheral artery disease, risk factors management, anything?
I don't know. I think we probably. I mean,
Yeah.
but it's such a complex issue. I mean, there's always more to
Mm.
talk about, but I can't
Yeah,
really think of
sure.
anything right now.
Well, I appreciate your time, Dr. Lee. Thank you again. This has been helpful, not only for me, but I think for the greater community. I think we talked definitely about what peripheral artery disease is. We talked about how we diagnose it, how we manage it, and how we prevent it. We also talked about the risk factors. Therefore, I want to encourage everybody, if you're smoking, stop smoking. If you're diabetic, get your diabetes under control. If you're hypertensive, make sure you have that under control as well. If you're immobile, start moving around. If you're obese, let's try to lose some weight this year to prevent limb amputation, essentially. And that's what we're here for. So thank you again, Dr. Lee. Again, this is Real Health Talk with Dr. Coring. We appreciate you guys. Love you guys. Peace. And see you next time. Bye.
Thank you, Dr. Coring.